Okay, picture this. You're scoping a patient with a bleeding peptic ulcer. Their vitals might be dropping, the pressure is totally on, and you have to make a split-second, high-stakes decision on the rebleeding risk and the management, right there in the endoscopy suite. So how do you categorize what you're seeing? And more importantly, what are you going to do about it? Well, that's exactly what the Forrest classification is here to answer. Let's dive right into the foundational framework, starting with the active bleeders, Forrest Class I. This breaks down into two absolute code red scenarios. Class IA is your worst-case situation. We're talking spurting arterial bleeding with a very high risk of rebleeding. Now, contrast that with Class IB. It doesn't have that arterial pulsation. It's an oozing bleed, but make no mistake, it is still highly active and carries a really high risk. Moving down the severity scale, we hit Class II, which is recent hemorrhage. Think of this kind of like a descending staircase of risk. Class IIA is a non-bleeding visible vessel, which keeps us squarely in high-risk territory. Stepping down to 2B, we find an adherent clot, and that sits an intermediate to high risk. Then, 2C drops us down to the low-risk zone with a flat pigmented spot. Finally, we reach the totally green zone, Class III. That's a clean-based ulcer where the rebleeding risk is very, very low.
Now, in the heat of the moment, you need to be able to recall all of this instantly, right? So to lock this in your memory, logically group the Roman numerals into three sequential buckets. Group I is active bleeding, think spurting or oozing. Group 2 is recent hemorrhage, think vessels, clots, or pigmented spots left behind after a bleed. And Group 3 is simply a clean base. It's really that simple. Active, recent, clean. 1, 2, 3.
So now that we have the classification locked in, let's look at the actual clinical management. For high-risk lesions, specifically Class IA, IB, and 2A, endoscopic hemostasis is absolutely mandatory. You literally cannot just leave these alone. Your toolkit here includes injection therapy, thermal therapy, or mechanical therapy like applying clips. And in actual clinical practice, using a combination therapy is usually your best bet to ensure you get complete control of that bleed. Now, here's a crucial insider tip for handling Forrest EB, the adherent clot. This one is super tricky. You can't just assume what's underneath it. You've got to actively step through the process of irrigating or trying to remove that clot. Why? Because you really need to reveal if a high-risk vessel is hiding right underneath. If you wash away that clot and uncover a high-risk stigma, you immediately pivot to performing endoscopic hemostasis. This breakdown brilliantly illustrates the dividing line in our clinical decision-making. On one side, you have your high-risk lesions, IA, IB, and IA. These absolutely mandate active endoscopic hemostasis. But on the flip side, you have your low-risk spots, I2C, which is the flat pigmented spot, and 3, the clean base. For these, no endoscopic hemostasis is usually required. You're mostly just going to manage them medically with proton pump inhibitor therapy and treat whatever the underlying cause is. Okay, let's distill this down to a major clinical pearl for the wards.
Definitely commit this clinical pearl to memory. Intervene for the red group, investigate the yellow group, and use medical therapy for the green group. To get specific, actively treat IA, IB, and IIA endoscopically. Always. Always check under the clot for IIB. And you can confidently stick to PPIs without endoscopic intervention for IIC and 3. If you remember literally nothing else today, just remember this rule of thumb.
Next up, we need to talk about the classic exam trap you might face. Pay extremely close attention here because test makers absolutely love to use semantic tricks to cost you points on your surgery boards. The most frequently confused lesion is Forrest E2A, a non-bleeding visible vessel. Because the term explicitly says non-bleeding, students so often falsely assume it's a low-risk lesion that can just be managed with medication. Please do not fall for this. It is a massive high-risk stigma. That vessel is practically a ticking time bomb, and it requires immediate endoscopic treatment.
All right, time for a quick recall test.
Let's pressure test what you've just learned to really cement this in your brain. Read this clinical scenario carefully. You are performing an endoscopy, and you see a peptic ulcer with a non-bleeding visible vessel. Think about it for a second, pause if you need to, and lock in your answer. Name the exact Forrest classification and the precise next management step.
Got it? Exactly right. It's Forrest area.
And because you didn't fall for that trap we just talked about, you correctly identified it as a high-risk lesion that absolutely mandates endoscopic hemostasis, utilizing techniques like injection, thermal, or mechanical therapy.
By mastering these specific distinctions visually and conceptually, you've pretty much just bulletproofed your GI emergency knowledge. You now know exactly what a spurting vessel versus a flat pigmented spot means for your patient's immediate future. So the final question is, will you ever fall for the non-bleeding trap again? And how are you going to apply this newfound confidence on your very next clinical rotation? Keep reviewing, trust the classification, and stay sharp.